My name is Morgan Similuk, and I'm a genetic counselor at the NIH. And it's just been such a delight to be with you guys all today at this presentation. And I know that there's a lot of friendly faces that I've seen over the years at the NIH. And, you know, for part of our role, we help our colleagues do genetics in the smartest way possible. And for part of our role, we help families understand what the genetic results mean for them and what it means for their lives. And there's a bunch of layers to that. And, you know, we really had no better teacher than you all on that front. And so it's just, you know, with great pleasure that we're with you today. So in genetics and in genetic counseling, you know, this is just a fictitious family, but we're really trained to think about that whole context, not just the person that is being evaluated for a primary immune deficiency or related problem, but the whole system that they come in. And that both has to do with, you know, things related to genetics and how diseases sometimes run in families, but also because the meaning of the results and the implications about how that's followed up with is, you know, intrinsically tied to how the family works and who's present and so on and so forth. So myself and my colleagues have sat with thousands of families over the years and talked with them about, you know, really fundamental questions that are tied to genetics, but are also just tied to coming to terms with what their symptoms are and where they come from and to what extent they can be controlled. And so these are questions that I suspect resonate with some people in the room. You can give me a nod or give me a big head shake if that's not the case. You know, why is this happening? Why is this happening to me? Where did this come from? You know, I think that there's, you know, key questions that have to do with ideology and sort of like where things started from, but also questions that have to do with right now. Like, how do I improve my quality of life to the greatest extent that I can? You know, what are the pieces that I care about the most, and how do I optimize those things so I can continue doing the things that I really care about while struggling or, you know, really doing well to manage other things that are more complicated. And then looking forward, right? The future is so important for all of us in our lives. You know, is it 5 weeks? Is it 5 months? Is it 5 years? How do I create a vision of what I want for myself, or what goals are going to be realistic? What goals are going to be attainable for yourself or for your child if we're working with a family? And sometimes that also includes decisions about, you know, building a family yourself. You know, lots of ways to do that. But these are all really important questions to us as people, and it's just such a privilege to get to talk to you all about these things. And you don't have to talk to more than about 5 families to realize that there are a lot of, you know, there's a lot of different ways to approach this, and there's just huge variation in families in terms of what they see as most important, what the strengths are that they, you know, the strengths or the resources that they rely on to make decisions and to go about their life. And, you know, it's just such a privilege to witness all of that and, you know, help families in our small way figure out how to move forward. So I just want to give a big shout out to my colleagues, the other genetic counselors that work at the NIH with me and specialize in immune disorders. I'm very happy and proud to say I think we have an absolutely dynamite team with different types of expertise, and I know that many of the families here we've talked to over the years. So Jai, who will be presenting with me today, and then Leila, who unfortunately had to leave town at the last minute, Mike, who's in the audience today, and then also Chenery, who's another part-time member of our team, is with us today too. I'm going to hand the microphone over to my colleague Jai for the genetics part of our talk.
Thank you, Morgan. Hi, everyone. So I'm Jai Yan, and I'm a genetic counselor also with the team. And I'm just going to give you a kind of a brief overview about the background in genetics and the context about genetic testing and what kinds of questions you might be thinking of when you're talking about genetics with your providers. So this is more of a background and framework to start thinking about a genetics discussion with healthcare providers, with genetic counselors, with your doctors, and your whole care team. So just to take a step back, this is just a background about genetics. So our body consists of millions of cells, and in each cell contains DNA, which is packaged into chromosomes. And the DNA provides instructions for how our body develops, grows, and functions, and it codes for genes and other elements. So there are individual letters of DNA that provide these instructions for how these genes are made. And in terms of genetic testing, to look at these specific letters of DNA, there are multiple methods, looking at the packages themselves in the chromosomes, looking at whether or not there is extra genetic material or missing genetic material, or looking at individual differences in DNA. So we are each 99.9% exactly identical, but there's a portion where people vary. Any two people may have different citizen letters called DNA variants. So genetic testing can look at these differences. There are a lot of genetic testing companies out there. Some of you may already be aware of some of these names. And what genetics providers, genetic counselors do is try to help you navigate these different companies. Exactly what are they testing, what kinds of questions they ask, and what kinds of information would you get back. So many different genetic tests are developed with a different purpose. And the point of having this conversation about testing is to try to find out what's right for you. Why would someone get testing? So there are many, many reasons that someone might. One is that for a person who has symptoms, who has a clinical diagnosis perhaps, or a cluster of symptoms, one reason might be to get a diagnosis. And at the same time, for someone who doesn't have any symptoms of a disease or does not have a diagnosis, one reason to test might be to see whether or not this person carries a DNA variant that could be passed down to other family members, to children. So one of the reasons for testing might be to plan for pregnancy or reproduction. And another is that it might help with risk prediction. So even if someone doesn't have a particular set of symptoms, it might help you predict what other symptoms you might have later on, or what symptoms you might have for planning medical care and prevention. And also in the newborn, there could be testing to change care of the newborn if there is a genetic diagnosis for a condition. Finally, for planning of a transplant, genetic testing is done to find appropriate matches and to be able to inform care prior to transplant and after transplant. And there's more information down here, so this might not be inclusive of everything. So this is just a background slide of the immune system. And as you can see here, the immune system is made up of many different types of cells. And a single DNA variant that might change the function of one cell, you can imagine, might actually change the way the cell interacts with all of the other cells, and might have an impact on genetics, on the function of the immune system as a whole. So the take-home message is that this is very complex, and multiple factors could change any number of these parts in order to impact the way the immune system works in response to infection. So what does this variable expression mean? So any person with a DNA variant might actually be different from another person with the exact same DNA variant. You can imagine that these two people have a number of other DNA variants that they each carry that in combination with many environmental factors that they might be exposed to would actually look pretty different despite the fact that they carry the exact same DNA variant. So with one single DNA variant, you might have a cluster of differences in symptoms or differences in severity of symptoms, even within the same family. And this will really depend on the specific gene change and the other factors that someone might harbor or carry or be exposed to. So genetics is complex. And one of the goals of genetic counseling and the roles of genetic counselors is to help guide and facilitate this complex decision making about genetic testing. What to test, what are the personally meaningful ways that this will change your care, your family planning, your personal risk perception and preparation, and also your adaptation to an illness. So an adaptation to symptoms or a diagnosis is very personal, and it involves many of the personal meaning of the experience as a whole, coping in terms of control over your health care and your situation, mastery over your how you take care of yourself and how you take care of your symptoms, and finally, the familial implications of genetic testing and genetics in your family, that it could affect not only you, but other families and other family members. And genetic counselors help you adapt and cope with these familial implications of disease. So here are some practical things to know about genetic testing in general. First, there is clinical genetic testing. So one of the reasons that people get clinical testing is to inform your healthcare and planning, and also to have some personal utility in terms of having information about what could be causing symptoms in you. How do we interpret a DNA variant? If we see that there is a change in DNA, we group them into different categories, ranging from benign or not having an impact on the way the gene functions in a way that is harmful for health and influences your clinical care, all the way to pathogenic, meaning that that DNA change changes the way a gene functions and impacts your care and your clinical symptoms. And then to something in between, or a variant of uncertain significance, where we can't say for sure that this is benign or this is disease-causing. And in these cases, we need more information to try to understand what this means. As with any medical test, there might be a number of questions that you are considering when getting testing for genetic testing. One is, what are the limitations for a test? What does it test? What does it not test? Also, who to test? Who would be the most informative person to get an answer in a family? And what tissue to test? Do you test blood? Do you test skin? Do you test saliva? What are some findings that you might get that are unexpected from a genetic test? And how would you pay for this test? Does insurance cover it? Does the lab have an out-of-pocket expense? And can I have a copy of the clinical report, and what does that entail? So here is an example of a clinical test report. So you can see here what we were talking about, the gene, and exactly what's the classification. In this case, it's pathogenic. And this has a whole bunch of other information. The takeaway message is that it includes important information about what the test found and what are the interpretations, what are the limitations and methods, and recommended actions. So this is something that's really important to hold on to take with you to your medical appointments, to have in the medical record, to be able to retain this information for all yourself and healthcare providers. And this is going back to kind of getting information about this from a test report will help you keep track of genetic testing to try to see, for those that need more information, maybe in the future we'll get more information and be able to have an answer for whether something that's uncertain is benign or it might be disease-causing. On the flip side, we talked about clinical testing. There's also research genetic testing. So this is a different purpose. As opposed to providing a genetic diagnosis, this is to help researchers ask about a disease and learn about a disease, ask specific research questions. So this testing might be different in the way the method works, the way it reads the DNA letters, and there are some questions to ask as well if you get research testing. So first is, does this study return results back to participants? Not all research studies return results. Does this study double check its results in the clinical lab? So if a research test uses different methods than a clinical lab, which has the goal of finding a diagnosis, then how does the research lab confirm its findings? Does this plan to reanalyze data? So for those variants, is it possible that as we get more information, we'll know how better to interpret those DNA variants? And in those cases of more and more research, then do we get more data? and get information back. Where does the data go? Does it get shared with other researchers? Does it get put into a public repository? What happens to your information after you participate? And what are some unexpected findings? So clinical research testing are pretty different, but they also have a substantial overlap in that you could learn information that impacts you directly. And some questions that come up about genetic testing in particular is discrimination. So back in 2008, there's a Genetic Information Non-Discrimination Act was passed, otherwise known as GINA, and that prohibits discrimination based on genetic testing from employment and health insurance. But it doesn't cover everything. So this doesn't cover other types of insurance like disability, life insurance, and active military members. And it doesn't necessarily match with state level provisions that may be stronger or weaker. And what matters most about when a test reveals risk of disease is that you don't know about how could that impact your healthcare profile and hence your insurance eligibility and premium amount. And there's more information about this from the National Human Genome Research Institute. So now Morgan is going to be talking about some specific scenarios to kind of translate all of this information into how that might impact an individual or a family in these sample stories.
Yeah, the technical aspects of the testing are really important, and it's a big part of our role to make sure that we do that as well as we possibly can. And my favorite part of my job is getting to hear stories from families about how their families work and what this information means to them. So in our best case scenario, someone presents, they have a number of symptoms, we do genetic testing, and we're able to provide a specific explanation for why they have their symptoms, right? That's a good situation most of the time. A number of things to comment on with that, right? So you can imagine someone presenting with, to be specific, common variable immune deficiency, for example. So it's a problem that affects antibody levels, and we then look at their genes and say, oh, it looks like this mutation in CTLA4 is the cause of your CVID. And so for many patients, they've been working for years to try to understand where it came from. So very often this news is a relief to them. And at the same time, it's also really loaded information, because then that opens up a whole new set of understanding about, could it get worse? What sort of things, had I been thinking about that are going to be less likely now that we know that this is the underlying molecular diagnosis? Do I need to shift my expectations in any ways? And oh goodness, does this mean that my son, my sister, my father, so on and so forth, actually are at risk for the same disease? And maybe they haven't come to clinical presentation, or maybe they have, but they're treated for something that's a little bit different that actually is part of this same syndrome. And so very often I know we work with families where this is a real shift in perspective from being a me problem to a we problem, or a me challenge to a we challenge about this actually could affect other people that really haven't been in the center of our radar screen. In our very best set of circumstances, this helps the physician colleagues that we work with manage people in a very targeted way. So change the medications that they're on, or start different prevention or prophylaxis, so that we're treating them in a really personalized fashion. That is certainly not always the case. And it's of course really interesting about how this plays out in families. And even when I've had the privilege of working with multiple people in the same family, right? Everybody has a different experience of the family that they're in, even if they grew up, at the same dinner table. And so people can take the same information and have really different meanings that they make out of what that information is, to be really concrete. Someone can say, wow, this is such a relief. I feel so much better knowing exactly what this cause is, and I feel like I now have something I can anchor onto, and I now have a more specific community of people that have the same disease. And then, their sibling could say, this is terrible news, right? I'm afraid of the things that this means for my future. This means that I probably won't be able to just get over this next cold or get over this next infection, but this is going to be a long haul, and that's awful. And often it's all of those things on the same day for most of us, right? Like there's just a lot of layers to this information for people. Yeah, so much more I could say. I'll stop there. I want to comment a little bit about inconclusive negative reports. So that's our sort of fancy word that we use for what otherwise in medicine is called a negative result. And so why we say negative is because genetics has really changed so much over the last many years that it is just so obviously apparent that what we know today is not the whole story. And a year from now, we're going to know stuff that we didn't know now, and 5 years from now, that you can really feel working in this field, the forward momentum. And so for all the families that we sit down with, most of them end up with this result. So because we work at a research hospital, we do a really big genetic test on pretty much everyone we see that sequences all 20,000-ish of your genes. And most of the time, we end up scratching our heads and we say we looked at all of this data and we looked at thousands of mutations that each one of us have, and we still don't know why in the world you have the infections that you have, or the infections and the autoimmunity or the autoinflammation, so on and so forth. And so this is the state of the science. This is where we are today, and a big part of our work on our team is to try to, help our program run so that even if we don't get the answer right or don't arrive at a specific explanation the first time, we can go back and revisit the data down the road in a systematic way, so that if we don't have an answer today, but it's possible to have an answer tomorrow, we're not missing it. We're not missing it down the road. And of course, this doesn't mean that something's not genetic, right? So the immune system is complex. If we knew the truth, right, if we could see who had major genetic factors that explain their symptoms and who does not, we can't answer that. We cannot answer that question. But some of our patients, genetics not involved with their symptoms. We don't know exactly who those are. We've got some guesses, but for a lot of patients, genetics probably are involved, and they're looking at a negative test report. So this is why we emphasize this inconclusive part of what we do. And just to, I was talking to a woman earlier this week who was in this situation, and she just said so articulately what I often feel, where she says, this really can't be it, right? I know that there's a genetic factor that underlies my problems in my sister, and I've been sick for so long, and it just makes no sense to me that you looked at all of that data and you found nothing. You didn't even find like a good place to start from. And that's just where the science is today, that there's a lot of cases that sure seem like we should be able to provide an explanation with a giant genetic test, and we just do not. So emphasis on inconclusive when you get a negative test report. And of course, in our world, in the research setting, we do these very broad tests, but most testing that happens is very targeted. So most clinical testing tests 6 or 20 or 200 genes that are implicated in the immune system. And in those situations, certainly, there's lots of stuff that's not looked at. Also, so this is in our world of research testing that's very broad, but also in the clinical world where sometimes testing is a bit more targeted. Occasionally we find things that are unexpected. The phrase that we use is, there's a couple different terms, but there are findings that we look for specifically, because if you generate a broad amount of data on a person and you're looking for why they have unusual infections, because we work with thousands of families, a fair number of them are going to have important genetic information in that data unrelated to their infections, but really important to their medical care. So there's guidelines that we follow in our practice about double checking everyone for about 20 diseases that are really serious, potentially life-threatening, and also quite treatable. And you have to, I'm sure you can imagine, then, sometimes we're in the role of calling someone and saying, you know what, we're not sure why you have infections, but I want to talk to you about the colon cancer in your family and some of the genetic information that we got that put that in context. So, you ask for an apple and instead you get an orange. And it's an interesting and a quickly changing part of clinical genetic practice to understand what's the best way to handle this information that both respects, the individual being tested and their preferences and their priorities, and also make sure that we're not missing opportunities to save lives with data that's, present, that we've generated, that's on our computer. And it's a really interesting area of practice. That's the piece on secondary findings. And then sometimes we find a different thing where someone comes and they have what we call a complex clinical picture. So they have a number of things going on. Maybe they have autoimmunity, they also have infections, and they also have seizures. And so sometimes when we look at the genetics, we can tell that this is likely to be one thing. So we've got one genetic diagnosis, and other people with the same genetic diagnosis have also had seizures. So we think this is a single explanation for all those symptoms. And occasionally what we find is that these are clearly two things, right? So that we look at the genetics and we find an explanation for the seizures, and we find a separate explanation for the infections, or something along those lines that let us understand that these are actually two different things. So, it was actually kind of an interesting challenge for us as we were talking on our team about what would be the most useful thing to talk to you guys about today. And I think the overall summary is that, we're just very interested and happy to partner with all of you in understanding genetics and making that work as well as possible in the PID field. And, on a family-by-family basis, to the extent that people are interested in figuring out what those results mean for them in their lives, and the implications in terms of their medical care, in terms of what it means to them socially or emotionally, or how it ripples out in the family. That's our skill set, and that's where we're happy to partner with you guys. So just a completely understated acknowledgement slide to say that it's just lovely to work with you all, and then also alongside our colleagues with different specialties. So that's all that we prepared, and I'm happy to answer any questions. So I'm going to read this question. I actually don't know the answer to it. So it's about HLA typing, and there's different types of genetic testing. And so, Jai was talking about a little bit earlier. So the question is, why is it that a sibling is only a 25% match for stem cell therapy or stem cell transplant with the same parents? And do any of the other genetic counselors feel confident on this question? I don't know if you would use like a recessive model in talking about that. Do you? Yeah.
Yeah, I think that which I'm not as familiar with the particular HOA match, but part of it is that even though siblings share 50% of genetic variation with each other and with their parents, that there could, in particular HOA, it is a complicated region with many genetic loci or genetic specific alleles, and there could still be recombination happening in parental chromosomes. So I'm not well versed enough to answer that specific one, but that there is diversity from when chromosomes cross over and make different combinations. Yeah, does that make sense?
This one is just a request to show this link about how to find a genetic counselor. That link there at the bottom, you enter your zip code, and it tells you who lives close to you that might be able to talk to you about these types of things. I can tell you that you're looking at, I don't know, probably half of the country's brain trust in genetic counseling for PID right here, but many genetic counselors can help you with these same sorts of problems, or even if they don't specialize in immune deficiencies, can help with questions that you might have that are related to inherited disorders that run in families. Okay. Yeah, this is an interesting question. So if a doctor runs a genetic test and finds mutations, should the patient then see a geneticist? Yeah, so I think that generally that can be useful. In the world of primary immune deficiency, it kind of really depends on what's going on at your institution and what kind of specialists are available to you, and where their expertise lie. So that would be the traditional approach. That a specialist might run a genetic test, and if it arrives at a diagnosis that's really clear, it can be handled by the immunologist if that's their area of expertise. It's also sometimes useful then to talk to the genetics team, a geneticist or a genetic counselor. Sometimes the results are really complicated too, so multiple VUSs and multiple genes, things that where you don't have the right and the inherited mutations that are causing a disease, but it seems like you've got at least part of the answers solved, where it can be then especially helpful to consult with a geneticist.
So the next question is, when testing to find out if a girl is a carrier, when is the best age to do the test? So this kind of a question goes back to the personally meaningful and also personally relevant information about testing. So question about what exactly this, by carrier, meaning that when someone doesn't have any condition but they actually carry a genetic variant that they could pass down, what exactly this condition is and what exactly they would be using this information for. So in some cases, a female does carrier testing at the time just prior to planning for a pregnancy, and usually in those cases a couple would do testing to find out whether or not they could each pass down a genetic change that could impact their offspring. In other cases, for an earlier onset condition, parents might get genetic testing and evaluation for a diagnosis. So this is a very personal and very individual question. So there's no answer about what exactly is the best age per se. It really depends on the goal of what this information would be used for. Okay.
Yeah, certainly. And I would also add, in the families that I've worked with, I feel like a lot of families have some preference, and there's also some support in the literature in letting kids be kids as long as they can, right? So that if you have a daughter and you know that she's at risk of perhaps carrying an X-linked disease, and she's 11 and she cares about things that you care about when you're 11 years old, being with your friends, that sometimes it's perfectly fine to postpone testing until someone's an adult. And in fact, some of the guidelines vary on this question, but some of the guidelines even recommend that, just saying that, once someone's of an age where they're interested in starting a family or building a family, that's the more relevant time for them to ask that question, and also to subsume control over that question, so sort of doing it on their terms, at their own time. And I can just say in my experience that that's not always 18, right? So when people turn 18, in my experience, they're very interested in leaving the nest and going to college and doing all of those things, and then sort of maybe circling back in their mid-20s once they've gotten over the big hurdles of transitioning out of the family of origin, and are sort of, thinking about their life and thinking about their future from a slightly different perspective. But, it's really individual to the family. I have another question here about how do we get genetic testing at the NIH? So, we were asked not to advertise for our research, which makes perfect sense. If you're interested in participating in research at the NIH specific to immune system problems, you can Google NIAID, so the National Institute of Allergy and Infectious Diseases, that's the institute that we work in, or NIH Primary Immune Deficiency, and any of those will lead you to web pages that have contact information for the study coordinators that manage our studies. And so there's a number of ways that things work, but essentially we typically ask people to come in for an evaluation, so take a trip to this area for an evaluation, and genetic testing is part of that workup. Okay, then we have several questions that are about very specific situations. So I guess I'll start with this first one that feels maybe easiest and most generalizable for me to answer. So, question about having a daughter. She is known to be, the testing's already been done. It's known that she's a carrier of CGD. What happens next in her early 20s? What are the next steps? And so here's some things that come to mind for me. And of course, this isn't, it's not really spelled out because it's different for different families. But especially if that testing happened when she was a kid, which is sometimes the case, I think it's really nice to just sort of circle back and revisit that conversation, either within the family or with a provider, like with a healthcare provider, if you'd like, to just make sure that everybody's on the same page and has all their questions answered to their satisfaction. You may or may not be surprised that sometimes I sit down with a young adult and they've had many medical appointments about their disease, but a lot of the initial early education happened when they were a child. And so I say, oh, okay, you have ALPS. Do you know what that stands for? Or do people ever wonder why you missed school, and how do you explain that to them? Like, what do you say? And, you may or may not be surprised that sometimes a lot of the initial education was targeted at their parents, and, they're just tuning in now, so they might not be able to answer those basic questions. So I've absolutely been known families where a child is known to be a carrier, and they've got a really specific understanding of what that means based on their siblings' illness experience, which may not actually generalize to what's true for them. So they say, this and this and this happened with my brother, and that means X, Y, and Z for me or for my kids, and might have some just really basic misconceptions. And so I think that that's sort of the best place to start. And this is a little bit more applicable to kids that are a bit younger than mid-20s, but it's really great all the time, is that when I'm thinking about a conversation with a family where we're going to be talking about new information or sort of revisiting information, I like to clarify for myself, what's the one or two things that I want this person to know when this conversation is closed? And those might not be medical facts, right? It might be that this is an ongoing conversation, you can ask me anything. Or this might be, a piece of reassuring advice, like this information doesn't mean that you're going to get sick, or it doesn't mean that you will necessarily have a kid that has the same illness. So those are sort of questions that I like to ask myself when sitting down with a family, or when talking with a family about how to disclose distressing information to other kids. Just as a way to kind of anchor the conversation to what's most important. So when asking what the next steps are for this 20-year-old, I think, a conversation about what the facts are and understanding what she's thinking. Maybe do a little bit of values clarification around, this is useful information mostly for reproduction. So does she want a family? Is she thinking about that yet? How does she feel about, parenting a child who has the same illness as her sibling or, as someone else in the family? What are the things that are most important to her about potentially being a mother? I think that's where the conversation should be. Would you have anything else to add?
Yeah, no, I think that's what Morgan said.
Okay, great. Let's see here. How's the time? Oh, 3:12. 3:12. Okay, so one of the other questions here that I think I can speak to. I don't have all the information, so I can't give a completely specific answer, but I think we can talk through a little bit is two different things here. So with this first question, so it sounds like someone had a panel of genetic testing, and so this means that it's a number of genetic tests sort of strung together under one package where you would test, a dozen or several dozen genes. And it sounds like the genes were all put on this one panel because they all related to inflammatory bowel disorder or disease. And here it says, so we did that panel, and then I'm positive for a mutation in the STAT3 gene. I think this says STAT3. STAT3 gene. So what does this mean? And there's a couple questions that I would ask myself. So STAT1 is I would be crystal clear on that mutation report if it says variant of uncertain significance, likely pathogenic, or pathogenic. So this is the formal rubric that Jai was talking about around how in genetics we evaluate the evidence for if we think that change, that misspelling, or that variant is related to symptoms or not. Okay, so if it says pathogenic or likely pathogenic, meaning we're either quite confident or we're pretty confident that this change is disease-causing, then what it would mean was that would be an explanation for a person's IBD. Now, STAT3 is a complicated example because you may or may not know that you can have different types of mutations in genes. Some of them turn the effect of the gene way up. We call these gain of function mutations, and different mutations in the same gene turn the function way down. And so you can have different types of effects depending on the exact type of mutation. So I would look at the report and talk to your provider about if they think that this is related to the hyper-IgE syndrome, Job syndrome, or if it's related to the STAT3 autoimmunity phenotype. And so that's the clarification, because then that's a different set of expectations and a different set of management strategies that would be on your provider's radar screen. And then I think the conversation would go forward from there, where you take a look at what the symptoms are that you have, and what's already known about either of those syndromes, and see if there's different ways that your illness could be managed, and then also who might also be affected in the family, because both of those are mutations that are commonly inherited from parents. Sometimes they're brand new in a person. We call that de novo. All of us have de novo mutations. Every new baby's got de novo or brand new mutations, and then sort of make an assessment about if there are other people that it makes sense to do testing with. And now this last question is about so I'm not. So this next question has some acronyms in it where I'm not exactly sure what exactly it refers to, but I believe what's going on is that this person has a primary immune deficiency. And then there's also a question about a polyposis syndrome in this individual. So they've had, my understanding is, some pathology done on tissue that suggests that maybe a familial type of colon polyposis might be part of their history, but it's not conclusive, right? And so this is like what is so common in medicine, right? You get a test result and it gives you a suggestion of something, but it doesn't definitively rule it in or out. So if I understand this situation right, I think what's happened is that there's been tissue testing specifically of the polyp, and that pathology suggests perhaps a familial pattern, a type of polyposis that runs in families. And the question is, what's the next step? So if I understand this situation correctly, a genetic evaluation would be the next step. So there's a number of genes that can cause polyposis that runs in family, polyposis meaning lots of polyps. And so sitting down with someone who specializes in cancer and talking about what those pathology findings were and what the personal and family history is, and then likely, if you wanted more information, selecting a panel of genes to test that could give you some information about inherited polyposis syndromes. Anything else? Okay. That's a great question. So, the way we go about that in our jobs, because this is absolutely a situation that oh, sorry, yeah. So this young woman said, okay, you have a mutation in STAT3. How do you know if it's gain of function or loss of function? There's essentially two things we do to get to the point about this. One is we look at the literature. And so if this specific change has been reported before in other people who have had hyper IgE syndrome or that have the autoimmunity syndrome with the gain of function, STAT3, this would give us a strong suggestion about whether or not it's gain of function or loss of function. And then because we're at a research institution, in those situations, if the clinical picture doesn't clarify, like, okay, we're talking about the autoimmunity, or okay, we're definitely talking about hyper IgE, and it usually does because they're pretty distinct clinical pictures, there are additional research tests that you can do where you actually look at the activity of STAT3 in someone's blood and how the signal is being transduced in that pathway to see if it's the function is amplified or downgraded. Yeah. Sure.
Thank you so very much, folks. We're almost to the end.